What I'm trying to do is talk about vaccines, and this is critical. Everywhere in the world, people are being vaccinated all the time. And, you know, the power of vaccines have been absolutely extraordinary. They've eradicated smallpox. Polio is in the end game, a 95% reduction in measles. And it's led to the world lifting up out of poverty. And what's critical about vaccines is that there's no other intervention in the world that touches so many lives. This is really extraordinary. This slide I borrowed from one of my mentors sitting next to me, Stanley Plotkin, which looks at vaccine development over time, and you can see, of course, that it started in 1798, a few vaccines, and then you see this acceleration that's occurred recently. So in my lifetime, we've seen 4 times the number of vaccines that were developed in the last in 150 years before that. So this is the basis of science that's moving. And what Gavi was established, about was because these vaccines were not being made available to developing countries. So here's an example, hepatitis B, a powerful vaccine that works against liver cancer and infection, and you can see a 12-year delay from when it started in the West. I was part of the original trial as a physician, being in the trial, not conducting it. And you can see that when Gavi was started, all of a sudden we see an uptick in engagement, and in fact a crossing over with the introduction in developed countries. And this equity issue is absolutely critical to access, and that's an important point as we talk about access. Here again, looking at hepatitis B, high-income countries to low-income countries, and you can see today more countries in low-income have hepatitis B than high-income. And over here, similar for Haemophilus influenza type B, you can see that in fact almost every one of our countries has access to it. Now, an example of how this spread has occurred has been the development of pentavalent vaccine. That's 5-in-1, it's DPT plus Haemophilus influenza plus hepatitis B. You can see it starting in 2000, and over time, watching it march. You don't really see the outline of the map here, so I'm sorry. Africa in the center, Latin America on the left, Asia on the right. And you can see the march across countries. And as of today, this is no longer a new vaccine. You can see one open hole right here. That's South Sudan. Didn't exist as a country when this was started. And in fact, it was supposed to be earlier this year because of the disturbance. It hasn't happened yet, but soon it will. So this is what we're able to do with access. So when we think about immunization, we talk about this, the reach of immunization. 83% of people in the world being immunized. But obviously, as we talk about global numbers, it hides disparities. And this is about DPT-3 coverage, which of course is an archaic vaccine, only used in 33 countries now. Here's what it looks like when you look at high income to low income, and you can see that 26% of kids in the lowest income countries still are under-immunized. And so you can see in the high income countries we're doing quite well. Now, what's important when we talk about access is that the original program, expanded program of immunization, which was started in 1974, had 6 antigens in it. And at that time, less than 5% of the kids in the world received these vaccines. So it was a very important program. There was, of course, a 7th antigen, smallpox, but of course, in '77, eradication was finished, and that vaccine was pulled off the agenda. But since then, there's been a series of other vaccines, and these are really important. Rubella already talked about, that Stan developed, but Haemophilus influenza type B, critical disease of children, and pneumo and rota, the 2 largest killers of children are pneumonia and diarrhea, and these are the 2 largest causes of those. Lastly, to be added to the list of globally recommended vaccine is HPVs. That's in adolescents, but I'm going to stick to the infant immunizations now, although, of course, at Gavi, we're working very actively now to try to bring HPV to the world's adolescents, and we hope to immunize 30 million girls in 40 countries by 2020. So what do we want? It isn't just to get the vaccines out and immunize. Ultimately, we want a fully protected child. We want that child to have all of the antigens that make sense for it and to be protected from these diseases. So where are we on that now? Well, as I've already told you, for the DPT-containing vaccines, we're up to 83%, but you can see that some of the newer vaccines are lagging behind, and this is the challenge that is in front of us in this next period. And if you ask the question, what percent of children are actually immunized with the 11 vaccines I showed you, not including HPV, you can see that 5% of the world's children are what I would call fully immunized, that protected against all these diseases. And what we hope to do at Gavi by 2020, assuming we succeed in our next replenishment conference, is to go ahead and try to raise that to 50% of the children. So this is about not just access to vaccines, period, but it's about expanding access to all of the potential antigens that are at least recommended now. And this looks at this in a graph form. You can see the reason the numbers are low now is because some of these vaccines are just being introduced in the developing world. Some of them, like rubella, despite having been developed many, many years ago. So what holds us back on access? And people tend to think about the cost of vaccines and other issues, but it's today mostly systems issue. It's the quality of the data, knowing where under-immunized kids are. It's the supply chain. It's the work that needs to go on reaching places that are isolated. And more, those aren't just rural areas, those are urban slums. And so we're going to be focusing on this in the future, but these are key access to determinants of whether we get this up. Now, the other issue that's important is the cost of vaccines and financing. And Gavi has a unique model, which is to try to make sure that there is no free lunch, that everybody pays. And so if you're a poor country, you pay a very small amount. That's 20 cents a dose for a vaccine. And hopefully over time, we're able to get prices down. But as the country moves from low income to lower middle income, they begin to pay 15% a year more per year, as long as they stay there. And then when they cross a threshold, which today is $1,570, then they graduate. And during that graduation period, in 5 years, they take on the full cost of vaccines, as shown here in the graph. What's important about this is that once they're graduated, now they have enough money, and I'm going to show you that, to presumably pay for these vaccines. But one of the critical priorities is that as we go forward, they don't get hit by shocks. And so we were very pleased to see an announcement 2 weeks ago by Andrew Whitty of GSK that said that he would hold Gavi prices for 5 years after graduation to make sure that countries had a chance to stabilize, and that's important. And then what we'd like to see, of course, is that if countries stabilize, then when the prices go up, which they will as countries get wealthier, that they go up in a reasonable level. And what we're trying to avoid is this, because this is what would cause countries to step backwards and drop the vaccines, and that doesn't do good for any of us. And so this is the work we're trying to do as a family, and of course Gavi includes vaccine manufacturers as well as all of the countries in the alliance. You might ask the question, is this sustainable? Does this make sense? And of course the challenge is we want a healthy vaccine marketplace. It isn't only about lowering prices. So if there was no Gavi subsidy, low-income countries would have to spend between 5 and 6% of their health budget on vaccines. And we all believe that that's probably too much, although I think it's the most cost-effective approach. But what we know is that with the subsidies, these are affordable for those countries. And most importantly, by the time they graduate, by the time their economies have grown, we estimate that 0.5% of the cost of the vaccine cost would be met by that percentage of their income. So 0.5% of their health budget, would be what it would require to pay for all the vaccines on average. That depends upon the birth cohort. It depends upon what vaccines they've adapted. But the point is that this is an affordable number. Obviously, it depends upon whether they prioritize it and put money to this and have the foreign currency, et cetera, and that's something we're working on. But one of the challenges that we're all going to deal with in access is that the world is changing. When Gavi started, 90% of poor people lived in poor countries with poor health systems. Today, 70% of poor people live in middle-income countries. And I'm just using one example. It's a special example here, India. And what you can see in this slide is that Uttar Pradesh, which is the second down, you see it's got a red box on it, its gross national income is $491, and if that was a country, that would be near the bottom of a Gavi country. And they have the second largest number of unimmunized kids in the world if they were a freestanding country. And as you can see, their coverage rates aren't particularly good. And so, what do we think about this situation? Do we say India is wealthy and therefore they should graduate, we don't worry about it, or do we need to worry about different states? And I could have put up Nigeria, I could have put up many different countries to make this point. So this is a real access challenge. Now, I've talked about some of the main things about access, but this panel is going to be discussing a range of issues. On the R&D side, how do we make sure that we get basic research, translational, clinical development, and that includes specialized research for developing country vaccines? How do we deal with manufacturing, pricing, and the quality of products, which is absolutely critical? And then on the delivery, I've already touched on supply chain data and health systems. And just to say that the world has created new mechanisms to try to deal with some of these. I was involved with product development partnerships. You can see there's a whole lot of them here. That's one way to think about developing new products for the developing world. Another way that was done was working with a developing country manufacturer. This is a vaccine, meninge A, which goes across the African meningitis belt. And of course, meninge A is a well-known vaccine, but a vaccine was made of just that strain. We immunized 153 million people over 3 years. And look at what's happened to the incidence here. You can see that the incidence has dropped down in those countries, at least the measured incidence, to 0 cases. So this is a really powerful public health effect. We also have pull mechanisms, and Gavi has an advanced market commitment to create a financial commitment to encourage R&D, to have vaccines that meet specific standards, and to incentivize companies to engage in this. And countries are assured, as a result of this, long-term pricing agreements. And you can see the rollout of the pneumococcal vaccine at a record rate here because of that. Now, we will touch on a few other things. Patents, is this a big issue for vaccines? In general, not, because it's mostly about know-how. But in some cases it has. Early on, when Chiron was very tight to have very tight patents around hepatitis C, there was a lot of upfront high royalty payments that made it hard for small companies and biotech companies to engage in this. On the other hand, we have situations where companies come together and say, we want to take our patents and waive royalties and make them available to try to assure access. So these are things we'll talk about with the patent pool and others in terms of moving forward. One of the important things that Gavi's done is it's made it possible for manufacturers to do what they want to do, which is to get vaccines out to the whole world. And Gavi is able to purchase vaccines now for 60% of the world's birth cohort. And as a result, we are able to work with manufacturers to create the type of marketplace that allows them to think about large volumes and relatively low prices compared to in the past where they often had low volumes and high prices. And this dynamic is changing, and we're discussing it with all the companies, but I think it's important towards access as we think about it. And let me just finish. I started at the beginning with all these great new vaccines. You know, what's coming down the pike? Well, we know that there's clinical trials now with a phase 3 malaria vaccine. Excuse me. We know that here in this city there's exciting work that's going on to try to bring a dengue vaccine forward. There will clearly be other vaccines that are going to be important. For me, obviously, HIV and TB are absolutely critical. We have to make sure we continue to research on these. In terms of other vaccines, we already have 2 cancer vaccines, but there are other known causes of cancer that are infectious. And I would argue that, in fact, we're going to have vaccines against things like type 1 diabetes, rheumatoid arthritis. Obviously, we don't know if those are caused by infections, but there's certainly been a lot of hypotheses that say that they are, and so I look forward to the day when we bring that science forward. So, just to finish, vaccines are one of our best investments into future generations. It's only true if we get those vaccines out. And the recent Lancet Commission said that if we could produce the tools we need, by 2035, we could create something that hasn't existed in the world. And just to summarize Larry Summers, the chair, saying this, basically the entire world used to be poor and unhealthy. And with the Industrial Revolution, some people got wealthy, and with that they bought better housing and better public health measures and vaccines and healthcare, and they became healthy, and the poor stayed unhealthy. But with the tools we have, and new tools, we could converge the health benefits and have one world where everybody is basically having the same health. So thank you very much for listening to me, and I look forward to the panel discussion.